first session was excellent. Now we know how to look after ourselves with the diet and exercise. The most important part is we need to build up strong bones, knee and hips. And that's our next session. It's musculoskeletal, talk about hip and knee disorders and osteoporosis. So it's my absolute pleasure to start with you all the next session, musculoskeletal. The first talk is hip and knee disorders by Dr. Adam Haddad. Thank you very much. Dr. Adam Haddad is a geriatric and general medicine fellow. He has a special interest in movement disorders. He currently works at Austin Health. Thank you very much, Dr. Adam.
Good morning, and sorry for the delay. So my name is Adam. We're just going to talk about the hip and knee osteoarthritis. So why OAs matter, actually. It's the most common disease, major cause of disability, and affects more than 240 million people worldwide, associated with reduced activity and mortality. And as we know, it's usually associated with lots of burden on the hospital admission, and in terms of cost also, it's quite costly for the government and the health system everywhere. High direct and indirect healthcare cost. Epidemiology and risk factor is knee osteoarthritis most common in the age at 45, and hip osteoarthritis is around 10%. So it's OA of the hip, of the knee, sorry, it's more common. Risk age, elderly more common. Female, obesity and prior joint injury, including sport injuries. Malalignment is usually, it drives the progression rather than lifting heavy things. Recently, definitely genetics and metabolic factors contribute to the OA. Most important to know about the OA is, probably you're all aware of it, it's not a wear and tear joint anymore. It's more just a whole joint involvement, including cartilage and bone, synovium and muscle and fat involvement. Mechanical loading and inflammatory pathways, and usually the most common pathogenesis of it is the imbalance. In catabolic, more than anabolic, which leads to the progression of the osteoarthritis, lead to structural damage and pain. Subchondral bone changes, which I believe our radiology colleague will talk more about it, is subchondral sclerosis, is remodeling and sclerosis, increased stiffness, bone marrow lesions, usually the best way to diagnose that is MRI, microfractural edema, and lead to pain generator. Altered load transmissions accelerate cartilage and damage, osteophyte formation at the joint margin, which also contribute to the pain and stiffness. In terms of pathology, is macrophage predominant synovitis in cytokines IL-6, MCP, and IL-2. Hence, sometimes they do benefit from prednisolone. Effusion and focal inflammation amplifies pain and structural progression. Modern understanding, as we said, is a whole joint disease, not just wear and tear, as we used to believe before. Molecular dysfunction, structural damage, and leads to the clinical disease. That's just a simple diagram showing the osteophytes. That's the osteophytes, and they will talk more about it. It's just at the edges of here, and as you can see, reduce the joint space narrowing. So cartilage breakdown lead to bone and bone contact. Osteophytes and inflammation cause pain and stiffness, and leads to reduced mobility, and it's a vicious cycle, reduced mobility, increased pain, and weight gain. So basically, it's the malalignment, it leads to load shift function in bone stress, bone marrow lesions, and cartilage damage, and that leads to OA progression. Bone marrow lesions is usually MRI finding, microfracture, necrosis, and fibrosis, and that reflects the abnormal loading and remodeling, strongly associated with the pain and progression. So the pain and progression is usually bone marrow lesion. Just simply about how you differentiate, because rheumatoid arthritis is very common presentation also to a GP clinic in terms of the general practitioner, And the pathology is different, but more common is osteoarthritis associated with elderly age and widespread one. So I'm just saying the imbalance between anabolic and catabolic of the osteoarthritis, and increased tissue degradation, which is catabolic, compared to the tissue repair, which is anabolic. So the key concept is catabolic activity more than anabolic repair, and net effect is progression of the cartilage loss. Failed repair leads to structural joint damage. And that's just showing the MRI finding of the osteophytes and cartilage damage in terms of the disease progression. Clinical presentation is activity-related pain, morning stiffness, less than 30 minutes, and functional limitation, especially in stairs and walking. People complain about that, and gradual progression. Diagnosis is very important. It's usually is a history and depends on the trajectory of a presentation rather than the clinical finding, because sometimes the patient presented with a severe OA, but doesn't really correlate with the MRI or the X-ray findings, which is, it's a clinical-based diagnosis. And the imaging and radiology, it's more support the severity of the diagnosis and leading further in terms of stratification if they need surgery or any radiological intervention, which they will talk or they have talked about it before. But yeah, it's the bottom line is a clinical examination and trajectory of the disease is more in correlate of the diagnosis and make you easy to come with the diagnosis rather than imaging itself. Non-pharmacological cornerstones, usually exercise, strength, and work, weight loss, and education and self-management, physiotherapy and bracing, and T-Chai and yoga. That's usually very important to increase the flexibility and help with the remodeling. Briefly, just in terms of the NSAIDs in OA, so the most common first line is topical NSAIDs, and it's quite good in terms of the renal. And that's just a simple diagram, simple table there about the role and efficacy and the GI risk, as you can see, and especially with NSAIDs, it's got significant side effect for GI and also for cardiovascular risk factors, especially for elderly people. Hence, probably the cornerstones is non-pharmacological treatment and topical steroids sometimes does help. What they will talk, the other thing is the intra-articular steroid injection, which I think my colleagues, they will talk more about that, and hyaluronic acids, mixed evidence, and also in terms of the stem cell as well. Opioids, just because I do Jerry, so basically it's minimal effect. It's got significant adverse effects associated with fall, and guidelines discourage using steroids. It does increase the 2 to 3 times of risk falls in elderly, hip fracture, femur fracture, and increase mortality and morbidity, and probably increase the rate of admission to the nursing home. Yep. So there are just the new things about further directions. It's more about moving from the symptom control to structural disease modification. There's cathepsin K, which basically it's block the osteoclast activity and the growth factor, and the WNT pathway, which regulates the bone and cartilage turnover. Just more evidence about moving towards the, rather than symptom control, and moving to structural control, disease, and modification. So treat the patient, not the X-ray. Exercise is the medicine, NSAIDs is mainstay, and usually start with the topical, avoid opioids, malalignments drive progression. Thank you very much.
Thank you so much, Dr. Haddad. And he finished before time, which is really great. A very interesting talk. Thank you. There will be an award for that from Dr. Ahmed later on. The next talk is intra-articular treatment for Dr. Wisal Al-Musawi. Dr. Wisal is a radiologist based in Sydney South, New South Wales. She completed her radiology training in Prince of Wales and Prince Henry Hospital in Sydney. She trained further experience in Sydney through the radiology fellowship with RINZCR. And she had previous experience working with pediatric imaging specialist at Westmead Pediatric Hospital, and later as a staff specialist at the St. Vincent Public and Private Hospital. She was also managing radiologist at Carina Private Hospital. Dr. Al-Musawi, she is now the managing radiologist at Loomis Imaging, Sutherland, and reports for Loomis Imaging Karina Private Hospital, and Luma's Imaging, Karimba. She has special interest in breast imaging, women's health, and intervention procedures, and enjoys teaching staff and students. Welcome, Dr. Wisal. Thank you.
Thank you very much for the invite. It's really a privilege. Thanks a lot. I'll try to make it very short and very simple. And this presentation is mainly actually for GP. So the objective of the talk is what GPs want to know, which is when to refer patient for injection, what imaging guidance, and I get that quite a lot, and sometimes they get confused what modality for what joint and why. How long does the relief last, and is it safe to inject? How often can we do it? And when should I refer the patient, the timing of the injection? So modalities, we're all aware of it. Mainly we use ultrasound. We used to use fluoroscopy. We hardly use it anymore because of radiation. CT-guided injection, I do quite a few of these. And with the new machines, it's a very minimal radiation exposure because we only choose like 1 millimeter slides just for localization. What are the medication? We're probably all familiar with corticosteroids. It's been there for a long time, and it's probably one of the safest. Hyaluronic acid, which is like what we use now is the Flexa. And with this one, we usually do 3 progressive injections 1 week apart. So it's usually 3 weeks interval. PRP, which is becoming very popular now, and I'll go through that. We use sometimes just local anesthesia, just marking, just as a diagnostic measure. Do we know if this joint is what's causing the problem and the reason for the pain? Stem cell therapy, mainly for knees and hips, and dextrose therapy. So for example, it's very commonly injected into the knee, and Dr. Rabea asked me to focus on knee and hip mainly, but we inject every joint in the body. The beauty of using radiology, and I try mostly to do hips because it's a deep joint and it's not easy to palpate. I usually do them under CT guidance. And the good thing of that, if you notice, okay, that's the marker, I guess there. So this is where the femoral bundle is, where the artery, the vein, nerves, what have you there. So if you do it blindly, you might go there and injure something. You don't want to go through muscle as well. So you try to approach it through fat planes in between the muscle to cause minimum damage and intervention. So we put the needle there, we localize where we're going, we know exactly, we have CT fluoroscopy. So I put the needle, I know exactly where my needle is. Sometimes I put a tiny little amount of contrast or even just air. If they're allergic to contrast, I know I'm in the joint. When they contrast or the air moves freely within the joint capsule, I know I'm inside the joint. You don't want to inject outside the joint because there's no benefit of the injection. You don't want to inject into the muscle because, let me control this here. You don't inject with inside the muscle, you end up with a granuloma formation or abscesses, or it's more risk. So that's why I always put a little bit of contrast just to make sure it's flowing freely within the joint. We do a lot of injections for the knees as well. If there is a small amount of fluid in the suprapatellar bursa, I usually choose ultrasound. It's straightforward, no radiation, short time. You just go suprapatellar, you inject again in real time. You see the tip of the needle, you see the medication flowing freely within the joint, so you know you are in the right space. Also, when we scan with ultrasound, if there's a Baker cyst, straight away I'll try to aspirate the Baker cyst and put a little bit of cortisone and local anesthesia there, because sometimes combined effect, this can cause more pain or that can cause more pain. Sometimes we're doing diagnostically. So I inject the Baker, aspirate and inject the Baker cyst first. If that relieves the pain, that's it, we stop there. If the pain is still there, we go back and we do the joint injection. And the beauty with that as well, if there is fluid in the joint, I always aspirate the fluid before I inject with PRP, with Euflexa, with cortisone, because the presence of fusion, first it causes tension, increase the pain, and second, it will dilute your medication. So it will minimize the effect. So always aspirate the fluid before you inject anything into the joint. Again, the beauty of doing it with imaging, I'm not injecting it into the infrapatellar bursa, I'm not injecting it into the quadriceps tendon and causing more damage than benefit. We do a lot of injection. I'm only choosing 3 joints, which are the most commonly used joints for injections. So the shoulder, we do glenohumeral joint quite often, especially for adhesive capsulitis. We can do hydrotherapy, where we use a larger volume. We mix the cortisone with local anesthesia, with normal saline, dilate the capsule, sometimes even rupture the capsule to give more range of movement. Or just for osteoarthritis. We also inject the suprapatellar bursa. So if the pain is causing by bursitis or tendinitis, we inject into the suprapatellar bursa. But if the pain is osteoarthritis, then we inject into glenohumeral joint. Sometimes we inject the AC joint, and sometimes we inject into the biceps tendon sheath. So it depends where the pain is. Corticosteroid, which, as I said, is the most commonly used. It's a normal hormone released by the adrenal gland, so it's a mimic to a normal hormone. What it does, it just helps to lower the level of prostaglandin and downplay the interaction between special white blood cells as an immune response to pain, which cause inflammation and cause more pain. So I always tell them what we try to do with corticosteroid is breaking the cycle where pain causes inflammation, inflammation causes more pain. So we're trying to break that cycle. That's why we mix the cortisone with long-acting local, which is Marcaine, just to ease the pain and ease the inflammation. Advantages of corticosteroid, which is the most commonly used one, is it's inexpensive, it's readily available, it's very potent anti-inflammatory agent, it reduces synovitis, and as I said, decrease cytokine activity, and it induces rapid pain relief. So if we want a short-term rapid pain relief, especially for sport people, where they have a game in 2 days or something, so that's when it's used if you want a rapid relief. This has advantage, it's temporary effect, it lasts, they say 8 to 12 weeks, usually my patients sometimes 3 to 6 months, they can benefit from it. It again depends on the severity and how your body will interact with the cortisone. Sometimes there's a minimal post-injection flare-up. Hyaluronate, which is Ioflexa, we're doing more and more of these, and as I said, we do it in 3 weeks, executive weeks, 1 week after the other. It's a very potent synovial proliferative agent, so it helps with the lubrication and work as a shock absorbent as well. It has anti-inflammatory effect, it's analgesic, and also it's a chondroprotective effect on the articular cartilage. And that's why it's now actually, a lot of them get referred to us by orthopedic surgeon. It has a little bit of minor side effect compared to cortisone, for example, because at the beginning, there will be a bit of pain, joint swelling, skin reaction, sometimes a pseudoseptic reaction, where the joint become tender, red, swell. It looks like as if there is septic arthritis. It is not a septic arthritis, it's just a really strong inflammatory response to the medication. I mean, there is a risk of septic arthritis, but it's minimal. So the advantages of Ioflexa, if we compare it to cortisone, it has a longer effect. It can last 6 months to a year, which is a good outcome, and has a very good safety profile. Disadvantage, it's very expensive, and it doesn't start straight away. It needs a couple of weeks before you can notice the effect of it. PRP, I know the lecturer before me said it's not common. but actually we're using it more and more now, and it's proven to be very effective. So the plasma, they take blood from the patient, they put it in a centrifuger, they take a highly concentrated platelet in the plasma, and we take it and we inject it into the joint. So what it does, it has growth factor. It's capable of stimulating cellular growth, increase the vascularity in the joint, proliferation, tissue regeneration, and collagen synthesis. So mechanism, as we said, it's a platelet concentrate. It has a growth factor, which stimulates healing. It's anti-inflammatory and cartilage support. Some of the disadvantages, again, it is expensive. It needs a centrifuger, so not every practice can use it. There is still ongoing trials to see the evidence-based benefit from it. But with using it more and more, we see more benefit. So as I said, they take blood from you, they put it in a centrifuger, they take the concentrated plasma, and we inject it back into knees and hips. Actually, they're using it now for a lot, like they're using it for cosmetic reasons to increase the collagen. They use it for hair growth. They're using it for soft tissue injuries, plantar fasciitis. So there's more and more use for PRP. A stem cell? Seriously? I'm not even at... Okay. I'll go through a stem cell therapy quickly. They take from fat, they take it from iliac bones, what have you, and they centrifuge it and re-inject it. Okay, so I'm not going through this. A lot of joint we can inject. The other one which we're using now is dextrose therapy. It's the same process. So we take 12.5 to 25% concentration. They inject it into the joint, and usually this one we use it when there's contraindication for other injectables. Sorry. So what are the complications for intra-articular injections? Infection, which is very rare, but it is there, and everything has to be sterile because we're getting inside the joint. They usually post-injection flare-up. Sometimes if you don't know where to inject and you inject under the skin, you end up with the skin depigmentation and skin atrophy. If you inject on a tendon, and especially if there's tendinitis, you might rupture that tendon. So that's why imaging comes handy. So what's the advantages of doing it with imaging? It's the accuracy, as I mentioned, is good for deep and complex cases like a GP or a surgeon tried that in the practice, failed, couldn't get into because anatomical variance, because patient had previous surgery, anatomy is changed, so it's used for deep and complex joint. It's diagnostic and therapeutic. Red flag identification, quite often they send me a patient for an injection and I find there's a fracture in the sacrum or something which is causing the pain. Or they're sending it for facet joint injection, I find no, there's a nerve root actually impingement, so the pain is coming from the nerve. So it's also identify and have red flag identification. Reduce risk of complications, so we don't inject into the muscle or a tendon or an artery or a nerve. And especially for a patient with hip replacement, post-surgical, because there's a lot of scar tissue, so you need a guided injection.
1 minute.
Okay. So what are the further criteria for GPs? Moderate to severe OA. If you are uncertain, you want to know if the pain is coming from that particular joint, and if a patient is waiting for hip replacement or arthroplasty. Contraindication, uncontrolled diabetes, severe coagulopathy, and prosthetic joints. We have to get very careful with that because we know with cortisone, it might increase the blood sugar in the blood. So you watch the patient for at least 2 to 3 days. Okay. Side effect, there's minor and there's rare. The rare one is transient hyperglycemia, tendon rupture, and infection. How often do we inject? Don't inject more than 3 to 4 times a year, please, because you'll end up sometimes with cartilage damage. So give apart, like at least 3 months apart between, and I'm talking mainly for corticosteroid, 3 to 4 times a year maximum. If it doesn't work, it means it's not going to work. So send the patient to orthoped surgeon or try something else. That's not the problem then. Why do we choose this than that? Steroids, they have shorter effect, but they're accessible. Hyaluronic acid has longer effect, lasts longer, but it's more expensive. Take-home message. So short-term pain relief, it's safe with appropriately selected. It's useful diagnostically. It's not a cure. I get that question a lot from the patient. So does that mean it will cure me? No. It's a temporary relief of the pain. It's temporary relief before your surgery. It's diagnostic to know that this is the part which is causing your problem and your pain. PRP is very promising. Again, what to choose, what medication, and when, it all depends on what joint you want to inject, on the severity and cost, if you can afford it or not, and the goal. Is the goal I'm waiting for surgery, or is the goal temporary relief for a sport person? Thank you very much.
Thank you. Thank you so much, Dr. Wisal, for such an interesting talk. Now it's my pleasure to introduce the next speaker, Dr. Mustafa Al-Tahir. Dr. Mustafa will talk to us about the surgical treatment. Dr. Mustafa is an orthopedic surgeon. He arrived in Australia at 14 years of age as a refugee from Iraq and attended Fairfield High School for 3 years before completing his undergraduate at the University of New South Wales from 2003 to 2008. He completed the Australian Orthopedic Association training in multiple centers of New South Wales and ACT and passed his fellowship exam in 2018. He subsequently completed subspecialty in surgical training and research fellowship at the International Bone Research Association fellowship in Switzerland and Spain, Prince of Wales fellowship in Sydney, New South Wales, and Macquarie University fellowship, Sydney, New South Wales. His main area of interest is lower limb arthroplasty, foot and ankle surgery, lower and upper limb deformity correction, trauma surgery, and osseointegration surgery with an implant and osteotomy guide design. So please welcome me, and let's welcome all Dr. Mustafa Al-Tahir for the presentation.
Thanks everyone for being here on a Saturday, giving up your valuable time. So I think there's going to be a lot of overlap with the talks that were given already, Dr. Haddad and Dr. Al-Musawi. So I work out of Macquarie University Hospital, Norwest Private Hospital, Campbelltown Private Hospital, and East Sydney Private Hospital. I do have some financial disclosures. I do some design work for Osseointegration International here locally as well. So that was already mentioned. I'll skip that slide. Why hip and knee arthritis in the setting of a GP conference? Obviously, it's a very common presentation to general practice, and it's increasingly prevalent as well in young patients. And I'll try and focus my talk on how to manage this in younger patients as opposed to sort of older patients, where I think most of you are quite well aware of the treatment options. So, you know, the approach that I use is more of a limb reconstruction approach. What does limb reconstruction mean? It's treating the problem as a biomechanical problem. So Dr. Haddad touched on it, assessing alignment, deformity in the joints, looking at joint orientation, trying to restore native anatomy and load distribution. And so that involves a lot of offloading procedures, especially in young patients, to try and avoid getting to the arthroplasty stage. Just to mention, we do have a no out-of-pocket joint replacement program at a couple of hospitals that I work at. So if patients are privately insured, they will be no out-of-pocket for their joint replacement surgery. So what are we talking in terms of arthritic knees? So anyone who's under 55, we know from the Australian Joint Registry database that their outcome from a joint replacement point of view, especially in knee arthritis, is they have a higher revision rate. So those patients, we try and avoid doing joint replacement, even in end-stage arthritis, if we can. Now, the etiology has already been, I think, mentioned, so I might skip that, as well as the pathophysiology. In terms of investigation, the number one thing that I think I would emphasize is the importance of x-rays. So in the general practice setting, I think the most important investigation to get is a weight-bearing x-ray, whether it's a pelvis, hips, knees, foot and ankle, hindfoot alignment views. The weight-bearing image is of utmost importance. Whereas, the MRI can give you a lot of information when there's intra-articular pathology that's a bit obscure. So if you've got a normal X-ray, if you've got an abnormal X-ray, the X-ray is pretty much what you really need. And so there are some advanced modalities in terms of X-ray. The EOS scan, which is based on a Nobel Prize-winning concept, but it gives you a lot of information from a joint alignment, leg length discrepancy, rotational profile, parameters that you get a report, and that report can actually outline a lot of things that you can interpret very, very easily. Are they varus valgus? Do they have a leg length discrepancy? Is there a rotational profile problem? And that can aid you in figuring out, do these patients have underlying misalignment that might benefit from our input. There is a weight-bearing X-ray that we have at Macquarie University Hospital as well, which has revolutionized our ability to look at so 3D modeling. I do a lot of 3D modeling. A lot of my deformity patients, we do real-time 3D modeling. They come in on 10 a.m. They have a CT scan. By 11, we've got a 3D model. We can go through it with them in real time in the clinic, and I can analyze their deformities and go through it and figure out if they need, and in real time as well, I can show you some videos of simulating corrections, figuring out if there is, especially in young patients, if they've got arthritic problems, if we can try and help them. Obviously, non-operative management options, everybody's spoken about that. I'll just mention offloading braces. There is a role for some offloading bracing in the setting of knee arthritis. If patients are varus or valgus, it can be poorly tolerated. It's not everyone's cup of tea, but in the patients who benefit from it, if they're young and they can use it, it might help them substantially while they're waiting for hyaluronic acid or corticosteroids or PRP to have an effect, and it might prolong the life of their joint in flare-ups to avoid going down the arthroplasty path. So when should you refer to an orthopedic surgeon? If there's failure of non-op management, persistent mechanical symptoms, patients who have significant alignment issues, and that's the key. So if you see a patient with alignment issue, even if they don't have advanced changes on X-ray, it is important to refer them early, because you miss the opportunity to alter the natural history or the progression of their disease. If they have severe varus or valgus, even as a 20-year-old, and they're already getting some symptoms, there is a role for us to see them and counsel them about the options. Because if you wait until they're 55 or 60, or sometimes patellofemoral arthritis in early 40s, they present with advanced patellofemoral arthritis, you've missed the boat. You're talking to them about partial joint replacement, and that's something that we can sometimes significantly modify. So what is joint preservation surgery? We try and offload, realign, and stabilize if they've got concomitant ligament problems, and repair any things like meniscus or labrum, or ligaments around the ankle if there is instability, to try and prevent that from causing further deterioration. So the aim is to preserve function. One thing I'd say is arthroscopic meniscectomies are done far too often. They're not joint-preserving surgery. They're a waste of time. All this triple-blinded, randomized control trials are showing now that arthroscopic meniscectomy actually leads to more advanced arthritis. And so patients really shouldn't have clean-up surgery for their knees. That's not a thing in 2026. So what do we do for those patients? I mean, if they present with medial compartment arthritis, they have varus malalignment. I'll focus on surgical treatment now. So high tibial osteotomy, that is a treatment that offloads. So if your medial compartment's bad, you take the pressure and put it in the lateral compartment. So the contraindication is if it's multi-compartment arthritis, then it's not going to work. So if somebody presents with varus, so they're bow-legged, and they have medial joint line pain, and they're young, there is a role for this treatment. Now, this is a video of the modeling. I don't know if it's going to run, but that's what I do in my spare time. I don't know if, is there a way to get the videos to run? Do you have a mouse, or is there a mouse? Oh, there is. It's running now. Okay. So that's what we do. You get a CT scan, you do a deformity analysis, you simulate the correction, and then you plan a patient-specific guide. We 3D print it locally. We've got a printer here, and then we can use it to accurately correct deformity. You can see this is a young gentleman. He's 51. He's got advanced medial compartment changes. He's got significant varus alignment. So pre and post, as you can see here, there's varus alignment. So the mechanical axis goes through the medial compartment where the wear is, and post-surgery it goes through Fujisawa's point, which is the lateral compartment, and he's had that correction. It helps prolong the life of his knee, and that's the plates put on, and then we can design some 3D printed guides based on that, so we can do accurate deformity correction. I might skip these because they can go on. So this is a patient who's 38. She presented with anorexia, medial hemicondyle collapse. So that's an extreme example, and she'd had, arthritis, septic arthritis shoulder, severe Charcot-neuropathy of the foot, and hemicondyle collapse here bilaterally. So that's a very complex problem. She's got pain, and she was an amputee. So we did a hemicondyle elevation, and that's very difficult to do without things like patient-specific guides. So we've elevated that, put some bone graft in here, and then you can see her sort of walking afterwards. So she's a bilateral amputee because of the Charcot-neuropathy, but at 38, she's still running, jumping, doing high-impact activity in sports. But you can see the deformity is corrected, and her mechanical axis is restored on that side, and she's got bilateral osseointegration implants as well. The other option is for valgus, which is knocked knee patients. If their lateral compartment's worn out, you take pressure off the lateral compartment and you put it on the medial compartment. That's done on the femoral side. So for patients who've got advanced patellofemoral disease, it also helps them, but it doesn't cure the patellofemoral arthritis. So often, if they've got single compartment involvement, we can use this sort of treatment. This is a patient of mine as well who had valgus arthritis. She'd had 4 arthroscopies, no pain relief. And she presented. I said to her, "It's a waste of time doing arthroscopies on valgus, varus aligned joints with overload of a compartment." So we did a distal femoral osteotomy. You can see her mechanical axis now goes through center, and also did a tibial tubercle osteotomy, lateral release, and corrected her patellofemoral tracking. So at 40-something, she's now going to avoid hopefully needing a joint replacement anytime soon. And that's putting a plate on, designing the guide, and doing the surgery. I'll skip there. So the other main part is patellofemoral alignment issues. So it's a very common presentation. These are the patients that, if not picked up in their late teens, early 20s, they've got dislocations or maltracking patella. It's really important to pick them up very early. Once they start having cartilage problems, you've missed the boat. So if they've got anterior knee pain, they've got instability, maltracking, issues with the anatomy of the patellofemoral joint, they need to be seen early. So there's no point in waiting until they're 35, 40, 45, because then I'm talking to them about partial joint replacement, which is not an ideal solution. So patellofemoral maltracking is multifactorial. You've got femoral anteversion, trochlear dysplasia, patella dysplasia, patella alta, lateralized tubercle, valgus alignment. If they've had a dislocation, they get an MPFL rupture, external tibial torsion. So rotational alignment, malalignment in any form, and then you combine that with ligament laxity, and it makes it quite sort of severe. You can see how far the patella is sitting, how high and lateral. in this patient, and this is a rotational profile assessment, so you can see the increased femoral anteversion, that the leg internally rotates in a prone position significantly, and it doesn't really externally rotate. So these patients would benefit from, so this is a 3D modeling. We check the rotational profile, check the angle, check their tibial tubercle to trochlear groove distance, and then I can do femoral derotation, tibial tubercle osteotomy, valgus correction for these patients, and prevent them from getting to the point where there is advanced arthritis. So this is sort of what we look at, all the parameters. This is an example. You can, let's go back. So this is a young lady. If the video plays, you'll see maltracking. That's a shame. Can you? Yes. So you can see her kneecap basically jumps, and so that is a very extreme example of a maltracking patella. And then once we correct that with a tibial tubercle osteotomy, that will disappear. This is an in-toeing patient, so that's a sign of increased femoral anteversion. And so she's got her foot pointing inwards as she walks, and that's a very clear sign that she's going to end up with patellofemoral arthritis issues. Ignore the sling that I'm in that video. So that's what we did. Bilateral femoral derotation osteotomy, that can be done through a keyhole approach, tibial tubercle osteotomy as well, lateral release, and corrected the misalignment. Hopefully that will prevent her from developing arthritis. There's also, we can do cartilage transplant, so we can get the whole of a distal femur, the whole of a talus, the whole of, any part of the body that has cartilage, and then fresh piece of bone with the cartilage, and take a piece and transfer it if we've got focal chondral pathology in young patients. So that is an option. It's an allograft transplant, and basically you take it from a donor, you create a hollow, and then you basically transfer that bone plug directly into the area that you need to fill. Joint replacement, there is options for partial or total. So partial is for patients who've got unicompartmental arthritis. They're lower demand, so offloading surgery is not going to be necessary for them, and we can do patellofemoral, lateral, or medial unicompartmental arthritis. That's good because you avoid changing the feel of their joint entirely. And then when I do total knees nowadays, we use a robotic-assisted approach. So this device, it's made a night and day difference in our ability to do knee replacements. So accuracy, looking at alignment, looking at a faster operation, less theatre time, and less pain issues for patients afterwards, and they get going much faster. So it's got a robotic arm, and basically comes in, we get a whole lot of parameters that I otherwise wouldn't sort of see used by feel. So, 0.5 of a degree, 0.5 of a millimeter, we check all these parameters, we map them, and then we get a graph, and then we can use that to do our deformity correction, realignment very accurately. I might skip that video. I'll just mention a couple of other things. Hip arthritis, very briefly. So there is an option. You're all well aware of patients who present with groin pain as opposed to greater trochanteric pain or buttock pain. The pathology is different, but patients who've got hip OA, groin pain is the primary symptom. Night pain indicates advanced disease. Doing surgery now, we do surgical planning using 3D planning of their problem with some x-rays that look at flexion, extension, their spine, because that has an influence on dislocation risk. And so we do that planning, and we can do an anterior approach, minimally invasive hip replacement, which in the future, very near future, we'll use the ROSA robot to do the hip replacement surgery as well. And then we can restore leg length offset and center of rotation. This is for young patients, so resurfacing of the hip joint as opposed to a complete hip replacement. This is an implant that's been released recently, and I think it will revolutionize treatment for young patients with hip arthritis. As opposed to having the entire bone stock taken out, you can just resurface the joint with ceramic on ceramic. I think it will revolutionize young patient hip arthritis treatment. I might stop here because there's a a lot more to cover maybe next talk. Thank you.
Thank you so much, Dr. Mustafa. That's a great talk. Thank you so much. Now our next talk is osteoporosis, and I would like to introduce you to Dr. Ziad Al-Uqaili for this talk. Please welcome Dr. Ziad Al-Uqaili. He's going to tell us about osteoporosis. Thank you, Doctor.
Thank you so much. Yeah, good afternoon, everyone. I'm Ziad Al-Uqaili. I'm from Baghdad, year 2004 graduate, proud graduate, and I have a few of my colleagues here. Thanks, Dr. Ahmed Al-Rubai, for inviting me. I'm a radiologist and nuclear physician. I've been working in Perth since 2010 at Fiona Stanley Hospital. And today I'm going to talk about where imaging fits in the decision-making pathway of osteoporosis. Because the issue is not about diagnosing osteoporosis, it's about identifying those patients who are at risk, who need early treatment to prevent fractures. This was from 2 years ago. I was so excited going back to Baghdad for the first time. Okay, so these numbers are confronting, and it's worth pausing on. About 2/3 of Australians, above 50, have underlying poor bone health, yet only small fraction get the diagnosis. And most patients actually present first with a fracture, and this is a shame. It's obviously devastating to the patient. It is associated with morbidity, increased mortality, and significant cost, both from loss of productivity and also cost to the healthcare system. So the system currently is reactive. Our job is to shift it earlier in order to identify those patients who are at risk, who need early treatment and intervention. This is the key slide of my presentation. And it's really a pathway that we all can follow to identify the problem and stump it in early on. And the first question you ask, simple question, is there a fracture or not? Because if there is, then you treat. You don't need to wait for further imaging or scan or risk stratification. It's as easy as that. However, if there is no fracture, then the next step is to stratify the risk for underlying abnormal bone health. And the first thing you do is by applying the FRAX score. After that, you perform a DEXA scan. Once you do this, you will have a clear risk of assessment of the underlying risk of fracture. And based on that risk category, then you apply the next steps of management. So if you remember really one thing from my talk, it would be this flow chart. Now, FRAX, what is FRAX? It's a fracture risk assessment tool. It's developed by the University of Sheffield. It's worldwide used. And basically, it gives you a 10-year fracture probability. You apply multiple clinical factors, including age, sex, smoking history, family history of fractures. And then the score, the tool will give you a probability risk, both major osteoporotic probability risk as well as the hip fracture risk. Then you apply, you add the BMD as a test to further refine this risk category. Now, DEXA scan is the cornerstone for the diagnosis of osteoporosis. It's a simple test, low radiation, reproducible, and standardized. But remember, it's only a two-dimensional density measurement of the bone. It does not provide you with a full bone quality. And you use it, obviously, to further refine the risk assessment based on what you have obtained from the original FRAX score. Now, what does DEXA give you? It gives you the bone mineral density measurement. As I said, it's an area measurement, so it's a two-dimensional measurement. It provides you with the T-score, and the T-score, according to the WHO classification, it's a straightforward. You get the categories where you define what's osteoporosis when the T-score is greater than 2.5, minus 2.5 standard deviation from normal population. And then between -1 and -2.5, that's where the low bone density or osteopenia category. It also provides you an input that you add on top of the FRAX score to further refine this risk assessment. So it's a good tool. You apply it, but it's not always sufficient. Because the risk is actually a continuous one. It does not suddenly appear when your T-score hits -2.5, the risk of fracture, I mean. So many patients who might be in the osteopenic range, they are still high risk for a fracture. And the T-score, two patients having the same T-score might actually be a completely different risk in terms of developing a fracture. Now, the interpretation of the DEXA scan, it is imperative to interpret this correctly, because first thing is that we do DEXA scan for two areas in general, the lumbar spine as well as the hip. Now, there are certain other areas that we sometimes do outside the lumbar spine or hip if there is contraindication or preclusion, such as the forearm or distal radius. Now, interpreting this is very important because the lumbar spine specifically is subject to multiple artifacts. Remember, you only refer patients who are elderly, most of the time, obviously, for DEXA scan. And when they do the lumbar spine assessment, these are the same patients who are likely to have endoplate degenerative changes of the spine. They're also likely to have calcification in that same region that we measure with DEXA, for instance, aortic calcification. They may also have artifacts from prosthesis. They may have metalwork, internal fixation from previous fracture, or other types of prosthesis. All these can lead to a falsely elevated measurements of the BMD. So the issue here is that if the numbers do not match your clinical picture, then question the number and always interpret this in a clinical context. So if I have to summarize the DEXA scan, I'll say it's a measurement of the bone density at mainly two areas, the spine and the hip. It provides us with a T-score for the diagnosis of osteoporosis, and interpretation matters because these scans are subject to multiple artifacts. So an interpretation always need to be taken in the clinical context. Trabecular bone score provides what DEXA cannot. It gives you information about the underlying bone microarchitecture. It is particularly useful in patients with diabetes and also those who are who have steroid use. So basically, it can identify those hidden high-risk patients for fractures. Now, this is where the decision-making is made. FRAX, as I said, it's a tool that is widely used, and it provides us with this 10-year probability of fracture. You apply it both with and without the BMD, and it gives you the MOF, the major osteoporotic fracture, as well as the hip fracture. So if your MOF is greater than 10%, then you move on and you do your DEXA scan to further refine the risk assessment. If it's greater than 20% or the hip fracture is greater than 3%, then this is a high-risk patient. You treat. You do not need to wait for the DEXA to tell you whether this patient has osteoporosis or not. You still do the DEXA scan because you need a baseline test to further monitor the progression of the condition or response to treatment, but you don't need to wait for this. Otherwise, patient obviously will be at risk of fracture. When the MOF is greater than 30% or the hip risk of fracture is greater than 4.5%, we're dealing with very high-risk patients. These are the patients where you need to escalate the therapy, and we'll talk about this in a second. Remember, FRAX always has limitations in patients who have diabetes or steroid use, or those who are at risk of falls. Then the risk can be underestimated with the FRAX. Usually these patients are at higher risk of fracture. And to simplify everything, this is the most simple explanation. Minimal trauma fracture is osteoporosis, full stop. This is where you need to treat the patient. You don't need to wait for a DEXA scan. The DEXA will only be complementary as a baseline for future monitoring. These are your very high-risk patients. Those with very high FRAX score, those with recent fractures or multiple fractures. In this case, you need to escalate treatment. Anti-resorptive treatment alone is not enough. You will obviously need to escalate to anabolic treatment in order to increase the bone density in this case. Vertebral fractures, unfortunately, are very common. They are often silent, and they get missed a lot. Both, patients can be asymptomatic. Obviously, we will not know that they have these vertebral fractures, or sometimes even when they have scans, we may ignore them. So important thing is that if we see these fractures, we need to identify them, because otherwise patients will not be on treatment. These are the things that will immediately change patients' management. And in reality, as radiologists, we see this all the time with CT, with MRI, and as I said, they're very common, and they need to get reported, because this is really the highest yield of imaging. Like, you have the finding there, and just simple reporting will mean that the patients will be on management for their osteoporosis condition, because, as I said, the development of a fragility fracture like this, insufficiency fracture, is on its own a diagnosis of osteoporosis. You don't need a DEXA scan. So. This is another, what we like to call a low-hanging fruit. There are information available in CT scan at our fingertips, but sometimes we don't tap on them unless we get asked to look specifically for, or we know about it. You can actually provide, as radiologists, we can provide significant information of the bone health just by measuring the density, what we call CT density. We have units called Hounsfield unit. And if we just measure the CT density at L1, literature says that you can classify patients into likely osteoporotic or osteopenic or normal. And you can help at least trigger a DEXA scan or the management pathway. The critical thing is we need to look for them. And because these scans are done repeatedly, many patients, all patients, will have CT scan sometime in their life. We just need to tap on this information. Now, management is risk-based. As I said, high risk, they will start anti-resorptive treatment, could be with bisphosphonate, with denosumab. But very high-risk patients, they will need anabolic therapy followed by the anti-resorptive treatment. And denosumab, obviously, should not be interrupted or discontinued. The timing of initiating denosumab is very critical. Research says that if delay in initiation of treatment, you are increasing the risk of fractures. And whenever it needs to be stopped, you have to cover with bisphosphonate. Otherwise, the risk of fracture relapse will significantly increase. The medication-related osteonecrosis of the jaw is a real risk, albeit it's quite low in the osteoporosis management dosing. Sorry. And in terms of scans, the monitoring, usually you obtain it as a baseline, and then you do a follow-up scan in 12 to 24 months to monitor treatment. And the most important thing about monitoring is that you have to hit a threshold. We call it least significant change, whether it's increase or decrease, because anything below that threshold, it could be just simple noise or artifact. These are patients who are at high risk for fracture, regardless of their fracts, those on steroids, those with cancer patients, and they need, obviously, need to be considered into the clinical context. I'm just pointing this slide because there are multiple MBS items available, so the issue is not really about access, it's about recognition of the condition. The key takeaway message, osteoporosis is very common, it's underdiagnosed. Radiology should change management, or imaging should change management. It's not about just reporting number, it's about identifying risk. And I'll finish with this very quick message to my GP colleagues. You treat after fracture, you perform FRAX assessment followed by DEXA scan, and those with very high risk, you escalate treatment and never stop denosumab unprotected. Thank you.
Thank you so much, Dr. Ziad, for such an informative session. Now I would like to introduce the speakers. If you can come back, Dr. Ziad, I will get the speakers to come for the Q&A session. And sorry, I couldn't find Dr. Ziad's slides earlier. He came all the way from Perth. He's a consultant radiologist and nuclear medicine physician at Fiona Stanley Hospital in Perth. He also subspecializes in oncologist imaging with focus in PET and CT. He's a principal investigator in multiple clinical trials, including PESMA and FAP, targeting therapies, and he is also a PhD candidate at the University of Western Australia, researching tumors, microenvironmental, and therapeutic strategies. Thank you so much. Now we have the Q&A session. We have time for a few questions, and if I please ask you to start by introducing your name and make the question short and simple. Any questions? Yes. We have the mic.
Sorry, for any patient on blood thinner, aspirin, Palaxia, or NOAC, or warfarin, do we need to stop this treatment before the injection? Thank you.
It was on one of the slides that I rushed through. Yes, definitely, especially if we're injecting inside the joint or if it's a nerve root. We usually stop it 48 hours. I mean, usually you weigh the benefit against the risk. If a patient has cardiac valve replacement and you can't stop it, then you can't stop it. You just use finer needle. You be as quick as possible in and out. You compress longer. But if you can't stop it, we prefer to stop it 48 hours before injecting. And if it's a bursa, I wouldn't worry about it. But if it's a big joint, hip, knee, especially post-prosthesis, then yes, I will definitely stop it. Next day. Yeah, next day.
Majid Labwood from the Gold Coast. I have a couple of questions to Dr. Ziad Al-Ugaili. When it comes to risk calculation of fracture, do you prefer to use the FRAX or the Garvin risk calculator? Is there any difference? Because we know Garvin has been developed here at the Garvin Institute in Sydney. Is there any difference or preference from your side? This is the first question. And then my second question, regarding the trabecular bone scan, I know it is a software. Is it covered by Medicare? Because when we send for the DEXA scan, not often we get back the report of the trabecular bone scan. Do we need to specifically ask for it?
Thanks, Dr. Majid. So first question, I work both in public and private, and at public we use Garvin, and private we use FRAC. So I think they're comparative. I don't personally have preference. I think they're both validated. You need one of them. As long as you have one of them, that's I think enough. The trabecular bone score, very, very informative piece of information. You don't need to pay for it. It's already part of the BMD. You just need to ask for it. Some of the softwares, the old machines may not have this installed, so they just need to update their versions, but it's available, it's readily available, it's part of the test.
Other questions? Yes, we have a question at the back. 2 questions. We'll probably stop after these 2 questions.
John from Sydney. Question to Dr. Wissal Musawi. What do you think about the steroid injection for carpal tunnel syndrome, and are they successful?
Carpal tunnel syndrome.
Oh, yes.
Steroid
Yeah,
injection.
we do use it. We do use it. And again, it's very important to use it with imaging because you know exactly with the needle, you monitor the median nerve throughout your process and you try to go in between the tendons and you see your cortisone. We use only 1 cc of cortisone, 1 cc of arcane. We mix them together, fine needle in between the tendons. It works. I mean, I get a lot of follow-up with the patient, and it does help a lot. Yes, we use it quite frequently. It's just because it was intra-articular, so I didn't refer to any other injections. But we inject, what I say to patient, whenever I can see something, I can inject it. So yes, we do inject them.
And I'll quickly ask, what in your experience, how long does it normally last for the carpal tunnel injection, the steroid?
Well, again, it depends how fibrotic the reticulum is, how compressed the nerve is. If it's really flattened, they will need surgery, definitely. It's a temporary relief. Usually we do it while the patient is waiting for the release of the reticulum. So it's straight, again, like any other cortisone injection, 12 weeks, 3 months to 6 months.
Thank you. Last question.
Sadia Hanna from Sydney. A question for Dr. Wissal. After hyaluronic acid injection, as mentioned, that could mimic septic arthritis symptoms with severe inflammatory response. So my question is, should we proceed with re-imaging and start active treatment to avoid the possible complication of septic arthritis, or we should go with method of rise and watch and wait? Thank you.
I'm so sorry, but the line was cutting, the voice was cutting. Where are you? I can't even see you. Okay.
I'm just here.
Sorry, what was the question in summary?
So after hyaluronic acid, if the patient could develop severe inflammatory response, should we reimagine and start active treatment to avoid the possible complication, or just we need to go with RICE method and watch and wait?
Usually it goes into 3 consecutive injections. So the first injection gives them a bit of pain and not much inflammation. The second injection will give them more pain, more inflammation. The third injection will again flare up and give them the pseudo-arthritic changes. We just wait and monitor them because the risk of real injection and septic arthritis is less than 0.1%. And especially if you use septic, everything is aseptic and everything is monitored. So 3 weeks, one after the other. Usually it works after a couple of weeks and will last 6 months to a year. If it doesn't help, then there's no need to repeat it because that means it just didn't work for you. And the damage of the cartilage is beyond repair by injection. It needs surgical intervention. So the risk of real septic arthritis is minimal. Sorry, I don't know if that answered your question.
Yes. Yep. Thank you so much. And I think we'll stop here. Well, thank you again for all the presenters for the great session. Now we will break for lunch. Lunch will be from 1 o'clock to 1:45. If I could please have you back at 1:45 so we can restart and be on time. Thank you very much.
Can I mention that we have posters, 18 posters, all displayed in the foyer there. And these posters will be assessed during the session for research in the afternoon.
And please make yourself well known to the sponsors outside. and get all the benefit that you can. Thank you very much. We'll see you back at 1:45.